Hello, everyone. Welcome to our live NCLEX Hour in Review session. For those of you who are just joining us for the first time, we are currently on day 20 of our 90-day free NCLEX review series, and we are covering a wide range of nursing topics, and we are going to tackle about 2,000 NCLEX questions with detailed explanations. So I want you to tell your friends who are preparing for the NCLEX about our classes. They're completely free of charge. Now, make sure to hit the subscribe button and turn on notifications, and make sure that you stay in the loop with our latest content. Now, if you need more information, kindly check out the description box below. And we also value your feedback, so feel free to drop your thoughts or questions in the comments, and we'll be happy to provide further clarification on any topics. Now, also, guys, we'd love for you to join our NCLEX review course. So if you can head over to our website at www.stancoastnclexcoaching.com for personalized assistance. Our program is all about making studying fun, and with engaging lectures and a huge collection of over 3,000 NCLEX style questions. So check out our 10-hour animated video course and get access to 100 hours of prep time, and also take advantage of our on-demand video library and practice with mock exams to build up your confidence. And this is something that you can do for 6-month full access, including over 200 NGN questions, and you'll be fully prepared for the exam. So you can study whenever works best for you with our flexible platform. Now, at Stancoast NCLEX Coaching, we're here to support you every step of the way. Now, guys, we'll be talking about the management for cor pulmonale and also the pulmonary edema. So let's get started. Now, let us define what this condition is. So you are seeing right now, first slide about the cor pulmonale. This is also known as the pulmonary heart disease. All right, let's just simplify this one. Again, this is known as a pulmonary heart disease, and this is caused by the strain on the right side. All right, I apologize about that audio. Okay, let me go back into the different causes of the cor pulmonale or cor pulmonale here. So let's go back into the acute or chronic pulmonary vascular diseases. So these are your factors. They're actually gonna cause that. Hang on, can you hear me right now? All right, I hope that you can hear me. All right. Now, with that pulmonary vascular disease, this is going to be a sudden flare-up, or it could be a long-term condition that could really mess up with those blood vessels. Now, of course, this is going to put strain into the right side of the heart, the right ventricle. All right. Now, there's also that factor which is known as the idiopathic pulmonary hypertension. Now, this is basically just a fancy name about the right-sided heart failure. And this is again caused by the increasing pressure in the arteries of the lungs that will skyrocket for no apparent reason. And again, it will also lead to the strain onto the right side of the heart. Again, guys, when you're thinking about the cor pulmonale, think about the right side of the heart. Okay? Don't get confused here. This is the easiest way to remember. So that is the cor pulmonale. All right. Now, as we are going to move into the different causes here, especially COPD, or let's say cystic fibrosis, or maybe interstitial lung disease. All right. So these are your lung disorders or diseases. So these conditions that we have named are actually going to mess up with your lung function, and this will make it harder for the oxygen to get into the blood. And again, this can cause overwork onto the heart for a long time. Now, if you have heard about the polycythemia vera, which is poly, there's many, cythemia, basically talking about the red blood cell. So there is excessive production of the red blood cell. And this is a disorder wherein the bone marrow will produce way too many red blood cells. That's why it's called polycythemia vera. And this will thicken the blood, and this will now force the heart to work harder to pump it around the body. Okay, so again, there is increasing viscosity in the bloodstream. Now, again, this will cause strain to the heart muscle to make sure that it can pump harder the viscous blood. Now, we're also going to talk about the sickle cell disease. So what is this? This is another culprit, guys, wherein those funky shaped red blood cells, those sickle cells, they're not going to maintain that biconcave type of form of the red blood cells. This is the own problem because it can really clog the blood vessels, including the ones in the lungs. And again, this will cause extra strain into the heart. All right, don't forget about the sickle cell disease. Now, there is also a condition called macroglobulinemia. So what is this? Basically, this is a type of a cancer, which is rare, but it can also contribute to the cor pulmonale by thickening the blood and making it harder for the heart to pump. Okay, that is the macroglobulinemia. This is a rare type of blood cancer. And there's also a condition, maybe a severe kyphoscoliosis. So when there is a structural issue, especially with the spine, this is going to mess up with the shape of your chest, and it will make it harder for the lungs to function properly. And then lastly in our queue is the obstructive sleep apnea. And I usually refer this as the OSA, obstructive sleep apnea. And so when the person who has this condition, when they are snoozing, their airway gets blocked intermittently. Okay, so this will cause them to stop breathing for short bursts. But over time, though, this can lead to high blood pressure in their lungs, and guess what? It will end up into cor pulmonale. Okay, so you see here the list is already long, but there are way too many others that I just don't want to include. But these are the primary causes of the cor pulmonale, and this is really going to set up this type of condition. But our focus really is to put emphasis that all these causes will actually put extra strain onto the heart by again messing with the lungs and also the blood vessels. And again, that problem onto the right side of the heart. Okay, so basically This is what we have as the right-sided heart failure, RSHF. Now, we're going to move into the different clinical findings or the features that you will see in a patient with a cor pulmonale. All right, so get ready here, guys, because there's so many of them, and you might probably see these manifestations with the other problems in the pulmonary circulation, or maybe with the cardiac issues as well. So I just want you to focus into those manifestations are really distinct into this disorder. So one is the fatigue. What is this? Well, or actually the tachycardia itself, or the tachypnea. So when the person has at least some strain into the right ventricle, this can really cause the person to compensate by elevating the respirations. And this is because of the hypoxemia, guys, because of course, there is poor exchange of the gases caused by the straining of the heart, and also in the pulmonary circulation, the body will not be able to really accomplish the exchange of gases. Now, there's also that exertional dyspnea. Okay, so the person will definitely have that shortness of breathing, and it will be more harder for them to breathe when they are doing something else. Maybe a regular daily exercise or an activity, they get really short of breath. Maybe a few distance of maybe just walking, or maybe climbing up a flight of stairs. This would be really difficult for them to do because of that dyspnea. And they're also going to be fatigued. Well, because of the poor exchange of gases, and also the decrease in the cardiac output. There is a decrease in the cardiac output because of the poor function on the right side of the heart, the right ventricle itself. So this can also decrease the oxygenation process and also the delivery of oxygen into the body tissues, especially the brain and all the other major organs. Now, take note, guys, that cough is also a manifestation in cor pulmonale. And sometimes they're going to end up with hemoptysis, okay? And this is because of the increasing pulmonary pressure that can cause the small blood vessels to rupture, okay? So we'll add here hemoptysis. Alrighty, so cough with hemoptysis, and then the patient will also have that anterior chest pain. Why? Well, because of the strain on the heart, this can also lead into an angina. Okay, remember that angina can be precipitated, especially if it's going to be influenced by, or it's caused by, let's say, an increasing need for oxygenation, or maybe if there is a greater strain on the heart muscle. So it will try to work harder. So they're going to end up with that anterior chest pain. Now, the person will also have that JVD, or positive jugular venous distension. Why? It is because the heart itself onto the right side. Okay, let me just create another diagram here. Supposing this is the right atrium, the right ventricle. Of course, if there is now backflowing or distension of the right side of the heart, there is overfilling, congestion. It will now cause the backflow of the blood into the venous system. Could be the inferior or the superior vena cava. And take note, guys, that we have our jugular vein right next to the vena cava. So with this condition, you will see that the person will have engorgement of the jugular veins, especially the external one. So even if they are sitting upright at 45 or maybe 90 degrees angle, it's even visible. Okay, so you will see that jugular vein so engorged. And this is not a common manifestation in a normal individual. Even if they are laying supine or 30 degrees angle, it should not be observed in a normal person. However, with the cor pulmonale, this is evident even when the person sits up. okay? All the more than when they are being placed in a 30 degrees angle, or let's say semi-Fowler's position, okay? Now, also, we're going to expect the person to have some peripheral edema, and I'm talking about swelling of the feet, the legs, or maybe some swelling into the sacral area. And this is again because of the backup of the blood coming from the right side. Okay, so this will now increase the pressure into the venous circulation. And again, it will be much more evident in the lower extremities, into maybe the sacral area. And over time, this can also cause problem into the portal circulation, especially the liver. Also, there will be increasing carbon dioxide levels. And again, it's because of the impairment in the exchange of gases. This will now cause a buildup of the CO2 in the bloodstream, and you can see this in the ABG results. Now, because of that hypoxemia, there's also going to be cyanosis, which is evidently going to be seen through blue tinge coloration of the patient's skin. All right, you might see this purplish discoloration around their mouth, or it could be the fingertips will be purplish or bluish. So guys, have you seen those patients that have like hypoxemia or chronic low levels of oxygen? Have you seen those extremities, their fingertips are actually kind of bluish? Yeah, that's a sign that they're not getting enough oxygen. Now, there's also going to be discomfort in the right upper quadrant of the abdomen. And I'm talking about the liver here. Because of the buildup of that pressure and the congestion of the blood in the venous circulation, this can now push back into the liver, especially the portal circulation. So it will end up getting enlarged, all right? And it will also cause some pain, and over time, this will lead into jaundice, okay? Now we're going to move into the next manifestation, which is basically fainting with exertion. So this is what we call as the syncope. They're going to faint. In our patient, that could be an elderly person. They're going to be at risk to developing those injuries. It could be a soft tissue injury, or it could be skeletal fracture. And so we got to be paying attention to those patients that may have this kind of nursing assessment or manifestation. So another is the split second heart sound. So what is this? Well, because of the increasing pulmonary artery pressure, this will now cause the delay in the closure of the pulmonary valve, which is basically right here. Let me enlarge this section. So here we have our pulmonary artery, and because again, there is an increasing pressure in the pulmonary artery, this will now delay the closure of the pulmonary valve or the pulmonic valve. And that's why when you're auscultating, you will be hearing that split second heart sound, okay? Now, let's exit out here. We are going to talk about the different diagnostic tests that the medical provider will be ordering. And top of the list here would be the chest x-ray. And what is expected in the chest x-ray is that there will be a right-sided heart enlargement. Right-sided heart enlargement. There will be dilation into the right atrium and the right ventricle. And again, it is because of the increasing pressure that was produced by the pulmonary arteries, right? And so this side of the heart, the right side, will get much more dilated. There will be increasing in its size, okay? Now, the 12-lead EKG, please pay attention here, guys. We really want you to pay attention regarding the changes in the EKG, especially in the case of cor pulmonale. So what's going to be seen here will be the following. There will be tall R waves, okay? And this signifies that there is now right ventricular hypertrophy. There is now an increasing size of the right ventricle. the muscle is hypertrophied. Now, there's also that appearance of the peaked P waves. So this is very unusual. And with that, this is going to be seen in a patient with the right atrial enlargement. So please pay attention. The peak P waves will be seen when there is now enlargement of the right atrium, whereas with the tall R waves, this is seen when there is now right ventricular hypertrophy. And moving forward, we also have the inverted T waves, and this is going to be seen in the precordial leads V1 and the V4. Okay, so the leads V1 up until V4. Now, part of that will be the low voltage QRS complexes. So when you are looking into the EKG, there will be that reduced amplitude. It's not really as gonna be seen as the normal elevation of those of that complex, and this is because of the low voltage. Now, we're also gonna be seeing some incomplete, or maybe an incomplete or actually complete. So let's get rid of this IN. So it's either incomplete or complete right bundle branch block. And this is because of the widening of the QRS complex. So you will see that. And of course, when you are gonna look into the echocardiogram, this will give us some information about the ejection fraction. Guys, please pay attention. When we are talking about echocardiogram, this is actually gonna give us some idea of how the valves are working and how the pressures are being maintained inside those heart chambers. Now, another thing that we need to pay attention here in the echocardiogram is the ejection fraction. So what is this? This is basically the amount of the pressure in percentage. And this will give us an idea of how well the ventricle is working, okay? And so normally, the acceptable ejection fraction is somewhere between, in some books it says above 52%, or in some books it says 55% and above. Okay, so this is our expected ejection fraction. Now, if there is a reduction in the ejection fraction, it simply means that the ventricle or ventricles are not really able to pump the blood from the right or the left ventricles. It's not able to really push the blood out into the lungs or into the systemic circulation. And so here we are really going to see that, hey, we are now seeing this patient with some form of a right-sided heart failure. Now, another thing that we're going to have to look at is for the patient that may have the right-sided cardiac catheterization, this will really confirm the diagnosis of the cor pulmonale, and it also will give us some idea of how bad the pulmonary hypertension is and the underlying factor as well. Now, what about the ABG, the arterial blood gases? Well, this is going to give us some information about the partial pressure of the oxygen and also the partial pressure of the carbon dioxide. And again, there will be hypoxemia and a reduction in the oxygen level, and possibly a decrease in the blood pH, which is going to signify there is some acidosis going on. Now, for the pulmonary function tests, the PFTs. So these are going to be helpful in giving us an idea that the cor pulmonale itself has been caused by the chronic illnesses, or let's say chronic conditions in the lungs, like COPD. So maybe a COPD in the form of the acute bronchitis, or it could be the emphysema. So if those values are gonna reveal those poor pulmonary function tests, then it could be caused by the acute bronchitis or the emphysema. Now, I really want you to recall on the diagnostic test that I lectured in the last few days regarding the pulmonary function test. So if you had forgotten about those, I want you to go back and review those testing, because there are so many values that will be involved in this diagnostic test. Now let's talk about the VQ scan. So what is this? Basically, this is going to give us an idea if the cor pulmonale is caused by maybe a pulmonary embolism that could have lodged into one of the major arteries. And again, it will also rule out, it will give us an idea if the high pressure in the pulmonary artery is caused by that blood clot. Okay, remember about that massive pulmonary embolism that I mentioned in the past, that it will now cause right-sided heart failure. Remember about the detouring of the blood flow when there is that blood clot? So mainly it will do that as well. Now let's talk about the hematocrit or the chest CT. Well, this is going to also capture regarding the kind of causative or underlying disease, which might reveal if there's maybe a pulmonary embolism or maybe an interstitial type of lung disease. So that would be helpful as well. And same thing with the hematocrit level. So what is this? This is really going to give us an information of how viscous the blood is. And I'm talking about the viscosity of the red blood cell, or the increasing concentration of the red blood cell. So good luck with me here. Let me just write it down. RBC elevation. Remember about the causative, one of the causative disease processes there when I said about the polycythemia vera? Yes, that can increase the hematocrit count, wherein it's going to tell us that the blood is so concentrated. There is way much more of the cells, the red blood cells, compared to the plasma. So your patient here will really have a viscous blood, very thick blood that can cause some strain into the right ventricle. Now there's also that alpha-1 antitrypsin, which I mentioned way back when I was talking about the emphysema. Remember that this is a deficiency, especially in that form of COPD. And so if this is going to be of a significant value, then this will pinpoint that the cause of the cor pulmonale is the chronic obstructive lung disease, which is the emphysema. Now let's talk about the anti-nuclear antibody level, which is going to be elevated, especially in the case of a collagen vascular disease. And lastly, we have the coagulation studies. And this is to give us an idea how the blood is really rapidly going to cause some increase in the coagulation. Okay, so it can easily probably clot. And so we're going to be able to tell if there is some issue with the clotting mechanism, or maybe there is just an abundance of those clotting factors, or maybe a genetic disturbance that is causing that one. Now let's move on into the management of the cor pulmonale. So pay attention here, guys. Now, the primary approach in the treatment of the cor pulmonale is really to address the underlying issue. And most often this is caused by the chronic lung disease. And we really want to make sure that we are going to manage the lung problem in order that there will be a reduction in the manifestations of cor pulmonale. Now, what would be that primary treatment? Well, since there is a problem with the oxygenation, we need to deal with the hypoxemia, right? And so the need for us to administer the oxygen is really critical here. We want to make sure that we are improving the oxygen delivery in order for us to reduce the heart's workload and also to decrease the sympathetic vasoconstriction. Because if there is hypoxemia, this will now also stimulate the sympathetic nervous system, and it will now trigger vasoconstriction, and it can also cause more of that problem. And so we want to make sure that this is going to be controlled through the administration of the oxygen therapy. And we are going to adjust the flow rates based on the levels, the PaO2 or the partial pressure of the oxygen, or it could be based on the level of the PCO2 as well, the oxygen saturation. And also, of course, we're going to have to look into the overall pulmonary function of the patient to see if they're improving. If their shortness of breath is relieved, then definitely we're going to have to at least maintain that oxygenation. Now, also here, we're going to talk about the targeted therapies. This is very important, guys. So we're going to talk about the pharmacological management about the cor pulmonale. And here are the medications. So one of those would be the prostacyclin analogs. And so these are going to be vasodilator medications. And we have our generic name. It's the epoprostenol IV. And there's also that treprostinil, which is given intravenously. And there is that inhalation form, which is the iloprost. Okay. So again, these are vasodilators. So it will actually going to act on into the pulmonary arteries. It will cause vasodilation. So when there is that change in the lumen size, especially in the pulmonary arteries, this will now cause relaxation, and this will allow a decrease in the workload of the right ventricle. Okay, so when that allows the pulmonary arteries to vasodilate, this will now decrease the workload of the right ventricle. That's the simplest explanation about the vasodilators. Now, talking about another medication classification is the endothelin receptor antagonist. And this is represented by the medication bosentan. And this is going to block the endothelin A and B. All right. So this is what we call as the endothelin receptor antagonist. So basically, the medication will target into the receptors, and it will now cause the vasodilation into that inner lining of the pulmonary blood vessels. So when this happens, this can also cause an improvement of the capacity of the pulmonary arteries. And of course, this will also decrease the pulmonary hypertension. Again, it will have a vasodilatory effect. Now let's move on into another classification here, including the PDE5 inhibitors. So what are these medications? These are your sildenafil and the tadalafil. So remember, these are actually one of those medications that are used in a person, especially the male, older population of male patients that may have what do you call this, ED. There's that dysfunction, erectile dysfunction. However, though, this is going to be a very useful classification of medications in a patient with a cor pulmonale. So it does really work, okay, for this patient, no matter what about the gender. So it doesn't work for this patient to treat the ED, but here, this medication will actually help out in relaxing the smooth muscles in the lungs, okay? So with these two medications in the PDE5 inhibitors classification, again, this will allow the relaxation of the smooth muscles and also the long blood vessels, and again, will decrease the pulmonary hypertension, okay? And this is really gonna target the COPD type of pulmonary hypertension, okay? So please pay attention. The sildenafil and the tadalafil. Now let's talk about digoxin. So I hope that you still remember what this medication is. Well, this is a cardiac glycoside. And this is one of the medications that is used for a patient with congestive heart failure. So the patient here will really get the benefit because the medication will actually strengthen the force of the contraction in the right ventricle right here. Remember about the dilation of the right side of the heart? And because of that weakening, it's not able to really pump the blood from the right side of the heart. But when we are treating the patient with digoxin, this will now strengthen the heart muscle in order for it to be much more effective in pumping the blood, and in order for it to deliver the blood into the pulmonary arteries, and the pulmonary arteries will carry the blood into the capillaries in the lungs for oxygenation. All right, and this will now be transported into the left side of the heart via the pulmonary veins, and then transported into the left atrium and the left ventricle. So again, think about the digoxin as one of those medications that can cause an increase in muscle or ventricular contractility. Okay. Increase ventricular contractility. So this is also what we refer as the positive inotropic effect. Contractility. Let me erase that. Okay, contractility. Again, this is what we call as the positive inotropic effect. Hello everyone, for those who just joined us, we are talking about the cor pulmonale, and currently we are discussing about the treatment. Now, part of the care here is the administration of the anticoagulants. Why? Well, the anticoagulants will actually work for the patient that may have the pulmonary embolism. Remember about the pulmonary embolism lecture, especially when there is massive or submassive type of pulmonary embolism, with a blood clot lodging into a huge portion of that pulmonary artery. In this medication, the anticoagulants will prevent the growth of that blood clot. Okay, and so this is something that will really give some, or it will really benefit the patient in order to control, or it will lessen the development of the right side heart failure. Okay, now another medication that we're going to expect in the treatment is the diuretic, and I'm talking about loop diuretic here, furosemide. Loop diuretic. Let me try this one instead. I hope this one will work for me. Is it working? Nope. Okay. So let me try my pen again. Loop diuretic, which is a regular, or actually this is a rapid acting diuretic, such as the Lasix or furosemide. This is going to cause excretion of excess fluid in the bloodstream, and will also assist the right side of the heart. It will decrease the strain into the right ventricle. So with that, the patient will really have some improvement. As soon as the medication works, within 5 minutes, the patient will start urinating in large amounts. So this will really allow a decrease in the strain, decrease in the exertion of the right side of the heart. But again, you have to be careful, guys. When you are delivering the diuretic, when you're injecting the furosemide, you also need to be careful about the complication that might happen after you deliver the diuretic. All right. Now we're going to have to focus into the cor pulmonale for now. Now we'll also talk about the other vasodilators, or maybe, yes, the vasodilators first. So this will include the calcium channel blockers, or the CCBs. And we have here the names: nifedipine, and this is actually sustained release, nifedipine sustained release, or SR, and diltiazem. So these are the known calcium channel blockers that will actually lower the pulmonary pressure. This will decrease the pulmonary pressure it has that vasodilatory effect. Vasodilation. So expect those two medications to be ordered. Now, there's also probably an inclusion of the bronchodilators if the underlying issue is COPD, let's say emphysema or bronchitis, or let's say asthma. The bronchodilators can also ease the overload or the overworked right ventricle. All right, so it will also improve the lung function and also diminishing the increasing workload of the right side of the heart. Okay, now let's move on into the next classification here. So what do we have? Okay, we also have the mechanical ventilation here, which is really going to help us out in treating the hypoxemia, especially if the patient is not able to maintain the level of oxygenation. And so this is really going to be helpful for those patients that may have a severe form of hypoxemia. Okay, so here we are going to talk about maintaining the patient's positive airway pressure. And of course, we really need to make sure that our settings are regulated and make sure that our patient is not getting way too much of that pressure as well. Now, another is sodium restriction, especially in the diet. So the patient's diet will be limiting the intake of the sodium. So we are expecting less than 2 grams of sodium in 24 hours. Less than 2 grams of sodium intake because of the increasing volume circulating within the bloodstream. We don't want to cause some more fluid retained into the circulation. Now, this time, guys, we're going to talk about the complications. And these are your respiratory failure. And because of the poor exchange of the gases, we really have to keep a close eye into the patient and make sure that we are prevent them from developing into this stage. And then also the dysrhythmias that can happen because of the increasing strain into the right side of the heart. This will lead into life-threatening dysrhythmias as well. Now we're going to go talk into the different nursing actions, starting with the nursing assessment. So what are we going to do here? We definitely need to assess the patient for any kind of history. All right, so maybe the patient will have a long-standing history of lung disease, and we have to get those information and also have to assess the severity of the patient's dyspnea, or the level of, or the severity of their hypoxemia. So how are we going to do that? Well, we're going to have to measure the patient's ABG, take a look into the values, and also looking into the oxygen saturation continuously. Now, we're also going to have to check for the patient's jugular venous distension and peripheral edema. Yes, the reason for that is because of the congestion of the blood, especially into the right side of the heart and the venous circulation. We're going to see of how bad the backflow or the consolidation or the congestion is in the venous system. So again, when you are doing this check, you have to put your patient in a 45-degree angle and to see if there is engorgement or distension of the external jugular vein. Okay, so that would be the appropriate way of checking this JVD. So we're also going to look for the peripheral edema. So take a look into the ankles, the legs, which basically will give us an idea that there is now retention into the lower extremities because of the right-sided heart failure. Now, we're also going to have to monitor the oxygen saturation, the arterial blood gases. So this will give us an idea of how bad the hypoxemia is affecting the patient. Okay, and this will also help us adjust the oxygen therapy as needed. Okay, guys, we'll talk about the oxygen delivery here. So we are going to administer the oxygen, and this is really going to be helpful in reducing the pulmonary artery pressure. And we want to make sure that we are keeping an adequate oxygen levels. But again, guys, remember about the lecture about the COPD. So you got to be careful. If your patient has cor pulmonale, we really don't want to administer highly concentrated oxygen, or we don't want to administer way too much of the oxygen because of its retaining effect. We don't want to cause a stop in their breathing. And so the best way to deliver the oxygen to the patient with a COPD is to deliver it through the venturi mask. Okay. Now, also here, we are going to avoid administering central nervous system depressants. So if in case there will be some prescriptions that have been ordered in the past because the patient will need these medications for a condition that they have, then probably this is the time that the doctor may have to order withholding some of these medications, especially like opioids or let's say hypnotics, because this can also lead into the respiratory, it can also suppress the respiratory centers in the brain, the medulla oblongata. And because the medications are known to cause hypercapnia, accumulation of carbon dioxide in the bloodstream. So again, we're going to avoid administering these medications, all right, the opioids and the hypnotics. And if really it's unavoidable, we really have to consult the medical provider about this. If it's really needed for them to really survive, then we have to be very cautious in administering the medication because of the respiratory complications. Now, we're also going to talk about monitoring the respiratory if there's any kind of infection, because with this, it can also cause retention of the CO2 and also hypoxemia. So it's very important, guys, that you will detect any form of infection, okay? Because this can exacerbate CO2 retention. Any kind of infection, especially in the lungs, okay? CO2 levels will be elevated if there will be infection. So what are those signs again? Well, recall about patient probably having fever, or let's say increase in the sputum production, or maybe a change in the sputum color. So please pay attention into those changes when the patient has a concurrent respiratory infection. And also, guys, we are going to monitor the patient for their fluid and electrolyte levels, especially for the serum potassium, because we really don't want to cause an imbalance here, and make sure that we really keep an eye into the important electrolyte, the serum potassium, because if we are gonna administer Lasix, or let's say if there is an involvement about the administration of digoxin, it's gonna make things more complicated. So make sure, guys, that your patient is not hypokalemic at this time when you are administering Lasix or when you are administering the digoxin. So let me write this down here. Especially these three medications are involved, you really have to make sure that the potassium level is within the normal range. Okay. Remember, guys, about the furosemide, that this is going to cause excretion of the potassium. And so if there is hypokalemia less than 3.5, and if they are taking digoxin concurrently because the patient requires to take it in order for it to maintain ventricular function, to increase the contractility of the heart, well, with that hypokalemia, it can lead into digitalis toxicity. Not a good combination. So please pay attention here, guys. This is very important. digitalis toxicity can occur in the patient if there is hypokalemia and if they are given the Lasix or digoxin. Make sure that the patient's potassium level is within the normal range. Make sure that you notify the medical provider right away. Hey doctor, probably we need to replace the potassium first before we're gonna resume the administration of Lasix and also the digoxin, because we don't want the digitalis to occur. Now guys, if you have forgotten about the digitalis toxicity, what are those manifestations? Well, in the elderly population, it can cause confusion. What else? It can lead into bradycardia. Let me just put here arrow down, HR, bradycardia, even as low as, let's say, less than 50 beats per minute. And we don't want any of that as well, right? Another thing is the ANVD, anorexia, nausea, and vomiting, and also diarrhea. A and VD, those are your signs of the digitalis toxicity. And also when the person looks into the light source, when they're looking into the any kind of light source, they're going to see halos, green coloration into how can we have those note? Lindy Filma, can you please elaborate your question? So we're talking about the digitalis toxicity at this point. And so we are going to have to focus into assessing those manifestation, especially if there is digoxin involved, if there is furosemide, or if there is potassium hypokalemia, focusing on that one. Okay. Now, aside from the hypokalemia, basically the digitalis can also digitalis toxicity can also occur if there is low magnesium level. Let me just put that Mg, or there is elevation of the calcium. So let me just put it here. Digitalis toxicity. So these are the common electrolyte imbalances that can occur or that can result to toxicity. Let me erase that. Toxicity. So one of those is decreased K level. Another is decreased magnesium. But the exact opposite here is that when there is increased calcium level, the note, I'm not quite sure what you're talking about. What note? How can I find them? What note? I don't understand what the question is. Are you talking about the notes that I'm writing on here on the PowerPoint? Okay, I'm not quite sure what's going on. Okay, if you could please clarify and I will answer the question. So guys, we are going to move forward here with the other nursing actions, especially in dealing with the cor pulmonale. And so there is also a need for us to make sure that our patient is monitored continuously, especially looking into their cardiac function. So make sure that we are going to capture those abnormal heart rhythms, to capture those. Let me see what's going on here. Can you still see my notes on the screen? All right. So I hope that you are able to see what I'm writing on the PowerPoint. So continuous cardiac monitoring, again, is going to help us in capturing those life-threatening dysrhythmias that we can at least treat before the patient will go into a cardiac arrest. Now, we're also going to have to limit the patient's physical activity during the acute phase, because really the patient need to have a reduction in the workload of the heart, especially the right ventricle. And we want to make sure that we're only going to allow much more of the activity once the patient is stable. Okay. Now, we are also going to have to talk about restricting the sodium intake. I think I've already said that. Again, the limitation will be about 2 grams and less than 2 grams rather. And this is to decrease the fluid retention. And then we're going to have to go into educating the patient, especially their self-care. So we're going to have to really emphasize in smoking cessation. This is something that would really going to help them out, especially if the cor pulmonale is caused by a COPD. Okay. And also, if with this, if they're going to be having that cor pulmonale because of the COPD, we really want to make sure that they are going to get that education, how the cigarette smoking can really affect the cardiac function, and also those modifying behaviors that they can do in order for them to start taking or using the cigarettes. So let me just check real quick what's going on here. Let me see. All right. So I hope that you can see this better this time. Now, we're also going to treat or recognize early signs of infection. We want to make sure that we are also treating the infections because, again, with that, it can lead to increasing CO2. And we want to make sure that our patient will have good quality of air, especially in the home setting. And we want to make sure that we are promoting good ventilation, and also that if there is some issue with their, let's say, air quality at home, maybe there's a need for them to really have an air filter or maybe some air conditioning as well in order to improve the quality of air in the home setting. Now, oxygen supplement. This is very important, guys, because they're really going to need to require the use of the supplement at home, and they might need to get some assistance, especially with setting up the device if this is the first time that they're using the oxygen. Now we're going to switch into another topic here about the pulmonary edema. So what is this? So basically, this is a problem that is caused by an excess of the fluid in the pulmonary circulation, and this is really gonna cause excess fluid in the alveoli, okay? Or it could be the interstitial spaces as well. Now, what is the cause here, and what is the mechanism of the pulmonary edema? Well, guys, the fluid in the alveoli will basically impede the gas exchange and also the movement of the oxygen into the pulmonary arteries. And so with that, especially in a case of left-sided heart failure, well, this is really going to make it harder for the patient to cause their breathing. It will make them so dyspneic. There are going to be some air hunger, and also the accumulation of fluid into the alveoli as well. So same thing with the MI, or let's say cardiogenic shock. This can lead to that as well. Same thing with aortic stenosis because of the increasing pressure into the aorta, or it could be a mitral valve disease. This can cause consolidation and also increasing blood into the pulmonary circulation. High blood pressure can also lead to that. And if in case, guys, you are probably treating a patient, an elderly person, maybe they have been dehydrated for quite some time, or let's say you are transfusing them with packed red blood cells, and they really have that decreased adaptability. If they also have some history of congestive heart failure, the increasing amount of the fluid through IV and also the introduction of the blood product into the system could really overwhelm them as well. So this might also cause that pulmonary edema. So you got to be careful when you are treating an elderly person or for those who have a pre-existing congestive heart failure. Now, same thing with the drug sensitivity. This can also lead to pulmonary edema, allergy, poisoning. Also, same thing with the pulmonary embolism, like I've said, because of its effect into the, what do you call this? The pulmonary circulation itself into the right side of the heart. This can impede the regulation of the pressure and thus causing accumulation of fluid into the lungs. And if there's also infarct or let's say history of stroke, trauma, pneumonia as well, post-cardioversion, or if the person probably just had some form of general anesthesia or an invasive procedure, let's say a cardiopulmonary bypass, this can predispose the patient to developing the pulmonary, pulmonary edema. Now, guys, we're going to talk about the, there's more here. High altitude renal disease, especially for those patients that are not able to excrete the body fluids because of the impairment in the kidney function. They're going to end up accumulating extra fluid into the circulation and will overwhelm the lungs as well. So here we go. Our patient will become dyspneic. They're not going to be able to maintain normal oxygen levels, and this will really cause some respiratory compromise and will lead to respiratory arrest if it's not dealt with accordingly. And same thing with the near drowning as well. Now we're going to talk about the different clinical signs that you should be watching for this patient with the pulmonary edema. Let me just check here. Are you able to see the video clearly, guys, or not? I'm not quite sure what's going on. Let me just take a look real quick into my slide. Okay, here we go. So for the assessment findings, take a look into the clinical signs here. We are gonna assess the patient for the most common findings, such as the coughing, the restlessness during, let's say, sleep. So these are the early manifestations. Okay, so when the extra fluids start to accumulate in the alveoli, this is going to make their breathing so hard, and especially when they are laying supine, when they are in a recumbent position, this will cause them to do the cough, and they will become restless, especially during sleep. Okay, now guys, let's also talk about the use of the accessory muscles. So what is going on here? Well, the person will be having to use those special respiratory muscles because this is an attempt. In order for the body to get some more oxygen, this will start using those accessory muscles to at least help with the breathing. And this is really a sign that the breathing is much more difficult to achieve. And also when the patient will be having that whitish or pink tinge sputum, then this is really gonna cause the mix the air, and also the it will create that pink tinge sputum because this is really gonna allow the leaking of the blood from the capillary into the alveoli. So when there is now mixing of the air, it will now produce that frothy sputum, and it will now indicate that there is some blood in the alveoli because of the buildup in the blood vessels and the alveoli. Okay, now talking about the severe anxiety here, or panic. So what is this? So basically, there is going to be that panic or severe anxiety because of the sensation that they are drowning in their own fluids, and this is going to cause them to have that intense fear, and also will lead into that panic attack. Now moving into the noisy breathing here. We're going to talk about the inspiratory and expiratory wheezing. So this is causing the bubbling sounds, the crackles, or also the narrowing of the airway because of the fluid that's inside the bronchioles. So you will be listening, or you will be able to hear those air movement through the wet passages, and this is going to indicate that there is significant fluid accumulation. All right, let me just pause this real quick. I don't know what's going on here. I hope that you're able to see the screen better. And if not, I'm not quite sure what's going on. Okay. All right. There is also going to be that bluish tinge color of the patient's skin. So this is basically the cyanosis, right? And that is occurring because of the poor oxygenation, and this is caused by the filling of the fluid inside the lungs. And of course, with the cyanosis, this really signifies that there is a lack of oxygen into the periphery. Now, the patient will also have some profuse, cold, clammy sweating. And again, this is a response to the patient's lack of oxygen, okay? Now, there's also that jugular venous distension, which I've already talked several times, again, because of the heart failure. This will cause the jugular vein to swell up. And again, another sign that there is a pulmonary edema causing the backflowing of the blood into the venous circulation. There's also going to be tachycardia, and this is because the heart is trying to compensate for the lack of oxygen, and also allowing the heart to compensate in order to circulate the blood more quickly. But again, this can worsen the fluid buildup inside the lungs. Now, the patient here will also have the tachypnea, the rapid breathing. And again, this is a compensatory mechanism because of the poor oxygenation, and hypoxemia is evident here because of the poor exchange of gases. And also the chest pain will occur, especially if the patient had the acute MI, then probably they're going to have a recurrence of the chest pain. And here, guys, please pay attention here, because oliguria can be seen in this patient, as we know that the kidneys receive about 20% of the total cardiac output. So take note about the decreasing blood supply to the kidneys. So what you're going to expect here is that the patient will end up with low urinary output. That simply means that the glomerulus is not able to receive or filter that enough blood coming from the system, okay? So again, there will be oliguria, let's say less than 400 mLs in 24 hours, or let's say less than 20 mLs per hour. This is what we call as oliguria. Okay, again, the reason for that, because of the decreased cardiac output and a decreased blood supply to the kidneys. Now let's talk about the different diagnostic tests here. So I hope that you're still there. And so one of those diagnostic tests is the chest x-ray, and this really can show fluid accumulation in the lungs. And this will be seen as having cloudy, there will be that whitish appearance into the lung fields. There will be also an ejection fraction of less than 55%. And like I have said earlier about the ejection fraction, this is going to signify that there is now weakening and ineffective function of the ventricle to pump the blood from the ventricles. Okay. Now talking about another diagnostic test, which is the pulmonary artery wedge pressure with the use of the Swan-Ganz catheter. So what is this? So this is really going to give us some idea about the pressure in the left atrium. Okay. So the Swan-Ganz catheter, so basically it is going to give us an idea. It will differentiate the cause of the pulmonary edema. And so the blood cultures will also be needed, guys. So for example, if there is an ongoing infection, we need to see if there is a pulmonary infection, make sure that we are checking on that before we're going to initiate the antibiotics in order to treat that, and may also help in decreasing the pulmonary edema later on. Now for the cardiac markers, so what are these markers? We are talking about the troponin I or T, the CKMB, or the myoglobin. So these are going to be elevated, especially if the cause of the pulmonary edema is cardiogenic in nature. So for example, if it's caused by MI, then our troponin I and T will be elevated. Same thing with the CKMB and the myoglobin. Now, another thing that we're going to have to pay attention are those BUN, the blood urea nitrogen, the serum creatinine, and the electrolytes, and also the complete blood count, because with those, we will be able to see some imbalances in the electrolyte levels, especially the sodium, potassium, and also if there is an elevation of the RBC, okay, or it could be elevation of the white blood cell count, which is associated to an infection, or maybe an imbalance in the electrolyte as well. Now let's talk about the increased BNP. What is the BNP? This is basically the beta natriuretic peptide. Again, that is the beta natriuretic peptide. So this is a hormone that is going to be released in the bloodstream if there is dilation or an increased volume in the ventricle. So the reason why the beta natriuretic peptide is released is that this is now the body's compensation, detecting that there is fluid volume overload. The body wants to excrete the excess water and also the sodium. So this is really just a triggering system. It will just like, hey, I'm just gonna send you a message. I'm gonna elevate the BNP in order for you to work on decreasing the excess fluid. However, though, the function of the ventricle is already impaired, and so the natriuresis is not really gonna occur at this point. So it's not going to be effective anymore, and so the patient will really benefit in if we are administering them the Lasix or the diuretic to get rid of the extra fluid, and also with the use of the the cardiac glycoside digoxin. Now we'll talk about the arterial blood gases, which is also going to be used in determining if the patient has some form of respiratory failure. We're going to see in the levels of the O2, the PaCO2, and we want to make sure that the patient is getting enough oxygen at this point. Okay. Now another procedure that we'll be expecting probably will be the thoracentesis. And so if the causative issue is probably a accumulation of fluid in the pleural space causing compression into the heart, then thoracentesis could probably help out while the procedure is removing the excess fluid from the pleural space. Now guys, we'll talk about here the lung ultrasound. So what is this? Basically, the lung ultrasound will detect the interstitial edema, and this is going to reveal this what we call as a B lines, or let's say the comet tall artifact. So look at this one right here, the tails that you are seeing in the ultrasound right here. So these are what we call as the comet tails, and this signifies that there is interstitial edema. All right. So that simply means that there is now a excess amount of fluid building up inside the lungs. Now we're going to talk about the management of the pulmonary edema. We have to pay attention here, guys, because our goal of treatment for this patient is to improve the oxygenation And we want to make sure that we're also identifying and also correcting the precipitating factor. And also we're going to have to reduce the lung congestion and the circulating fluid volume. Okay, so that would be the goals of the therapy. Again, improve the oxygenation. We're also going to have to reduce the workload of the heart and also the lungs by decreasing the congestion and also decreasing the circulating blood volume. Now, we're also going to have to administer them the oxygen. And the reason for that is to correct hypoxemia, as easy as that. We're going to have to incorporate the use of the non-invasive ventilator or ventilation, or the use of the BiPAP. And this is going to be one of the first line interventions, especially when your patient is really in that grave danger. And they're going to be allowed to wear that mask to maintain the ventilation and also oxygenation. Mechanical ventilation will follow through. If the patient is not going to respond to the BiPAP or the non-invasive ventilation, then they're going to require intubation and managing the ventilator setting as well in order to reduce the amount of blood returning to the heart and also reducing the workload of the lungs. Now we're also going to talk about the morphine. So what is the use of morphine in the treatment of pulmonary edema? Well, the morphine itself can reduce the anxiety, and it will also promote venous pooling of blood in the venous system. So this will decrease the preload. Guys, this will decrease the preload. It will also decrease the anxiety. So when the patient's anxiety level goes down, this will also decrease the workload of the lungs and also the heart. Okay, so that's why morphine can be important. But guys, please pay attention into the pulmonary function of the patient. They're already dyspneic. So if in case this medication might not be applicable, so you really have to be cautious when you are administering this medication because it can cause retention of the CO2. So you really have to do your clinical judgment here. Make sure that you think if this medication can really benefit the patient or not, or maybe it can harm the patient. So either or, you have to be careful in administering the morphine. Now, also the administration of the vasodilators, especially nitroglycerin or the nitroprusside. So maybe in a case of a pulmonary edema, the medical provider might order the application of the nitrobid patch, let's say the ointment type of nitroglycerin that can be applied with that a little bit of a tube that you can apply on a piece of paper that is measured, and this is going to be applied into the chest wall of the patient. And again, we know that the nitroglycerin is effective in causing the vasodilation. And so when this happens, this will now decrease the preload, which is basically decreasing the entry of blood into the heart. And it will also decrease the vascular resistance, which is basically the afterload. And so the patient will really feel some relief as soon as the medication starts to take effect. And I've seen this many times when I was a brand new med-surg RN, especially for those elderly people that may end up with the fluid or volume overload if they have a pre-existing congestive heart failure. I've seen the use of the vasodilator. It's really effective, guys. They're really gonna have the some relief with the difficulty of breathing because of the vasodilatory effect. But again, with that vasodilation, you'll have to watch for the patient's blood pressure when you are administering this medication, because it can also cause some drop in their blood pressure. So let's also talk about the diuretic, which is the furosemide, which I've mentioned several times already. And so the reason for that is to decrease the intravascular volume. We really want to make sure that the patient is not going to be overwhelmed with the increasing fluid volume. Okay, so that's why we want to get rid of that fluid that is in excess. And so we're going to give this medication most often IV form, and the onset of action for this medication usually will start within 5 minutes. Okay, so that is how rapid the medication can work for this patient. 5 minutes. And then you will see an increasing amount of urine that will be produced, and also the amount of effort that you have seen in this patient will actually going to be decreased once the patient will urinate a big amount of urine. Now we're going to talk about the increased cardiac contractility. What is this? Well, of course, this is pertaining to the use of the cardiac glycoside, right? We talked about that earlier, strengthening the muscle force, which we call as the inotropic effect. So this is what we call as the positive inotropic effect, meaning there is increased contractility of the heart muscle. This will really improve the pulmonary edema. Another is the use of the dobutamine, which is an inotropic, and this is a sympathomimetic amine, and this is also going to stimulate the beta adrenergic receptors, which will help the increased contractility of the heart muscle, okay, and also improving the cardiac output. Okay, so let's point out here, the digoxin will increase the cardiac output. Same thing with the dobutamine. Okay, and the next medication that we will be expecting here to be included in the therapy will be the neceritide. So what is the neceritide? This is a vasodilator and a synthetic form of the beta natriuretic peptide. So what is the mechanism of action for this neceritide? Well, it actually will mimic the effect of the endogenous BNP. And so this will now cause the vasodilation, and it will also cause a reduction in the preload. It will reduce the preload and also decrease the afterload. Okay. Now, the neceritide will also promote diuresis. So it has so many effects, guys. It will cause excretion of urine. So you're basically going to expect that the patient's breathing will be improved once they start taking this medication. So think about vasodilation causing the preload to decrease and also a decrease in the afterload. Now, there's also another medication here we call the milrinone. So what is the milrinone? The milrinone is one of those phosphodiesterase 3 or the PDE3 inhibitor. And the effect of that medication is also to inhibit the phosphodiesterase, and it will now cause increase in the ventricular contractility. Increase ventricular contractility. And again, strengthening the force of the muscle contraction by the heart. Again, the patient with the CHF will benefit from this medication. Contractility. So that is again the milrinone. All right, so basically these medications will have similar effects into the heart muscle. It will improve the contraction. And again, we'll just use the term positive inotropic effect. All right, so please pay attention. Those medications will improve the heart muscle pumping ability And so this will really help out the patient with a pulmonary edema. Now this time, guys, we'll talk about the use of the intra-aortic balloon pump. So what is this? This is another modality of treatment that will be helpful in a case of severe pulmonary edema. And so the main goal of the use of this instrumentation is to decrease the afterload. So we are talking about decreasing the systemic vascular resistance. Okay, decreasing the systemic vascular resistance. So let me explain to you first, what is that systemic vascular resistance? Supposing this is the heart, and we are focusing now into the left side of the heart, the left ventricle. And remember, guys, that when the blood gets pumped into the systemic circulation, we are going to see that the blood is expelled via the aorta, right? So this is the left ventricle here, this is the left atrium. And so the systemic vascular resistance really is gonna cause some strain into the left side of the heart. So what is the systemic vascular resistance? This is the amount of pressure that the left side of the heart is actually going to overcome. Okay, so for instance, let's say there is, hypertension, or maybe aortic stenosis. There is a problem in the structure in the aorta itself. Well, the exit of the blood coming from the left ventricle will cause a whole lot of intense pressure into the left side of the heart, especially the ventricle. So if the pressure goes up, if the SVR goes up because of the hypertension, well, what do you expect? That increasing pressure will now cause the ventricle to work harder. It will cause the ventricle to push harder, make it exhausted. At some point, it will no longer be able to pump effectively the blood. So this will now lead into that left-sided heart failure, okay? Now, talking about the use of intra-aortic balloon pump, let me erase this. The intra-aortic balloon pump actually is a device that is going to include the placement of the balloon into the descending aorta. So let me increase the size here. So the balloon is actually inserted via the either the femoral artery, or it could be entered into the axillary artery. Okay, so it will be introduced there, and the balloon will be lodged into the aorta, since it's called intra-aortic balloon pump. So the device will really help the heart to pump the blood more efficiently, and it will improve the blood flow to the heart muscle, which can be helpful in treating the pulmonary edema. So what is the mechanism of the IABP, the intra-aortic balloon pump? So basically, guys, when this happens, when the balloon pump is inserted, it will be regulated by the external machine, right? So it will be connected to a certain tubing that will be regulated by the machine. So with this, the setting of the balloon is actually going to be synchronized with the cardiac cycle. So the balloon pump, or the balloon itself, will inflate, it will also deflate, and this is going to be synchronized according to the cardiac cycle. So for example, during the diastole, this is going to allow the balloon to inflate. So this will cause the balloon to grow bigger in size. So when we are taking a look here into the balloon inflating into this area, okay, let me just exit here. we have a better picture. When the diastole occurs, so take a look here. The balloon will get inflated. When this happens, this will now increase the aortic pressure. When this happens, the blood will be able to perfuse into the coronary arteries. Okay, so it will not be able to perfuse enough oxygen into the coronary arteries. And also during the systole, this will cause the balloon to deflate. So right here, the size of the balloon will grow small, or it will become smaller, and it will now decrease the aortic pressure. And so when that happens, this will now decrease the afterload. So basically, the workload of the left ventricle around this time will be much lesser. So the heart will pump less harder around this time, and this is really going to benefit them, because with that, the heart's cardiac output, of course, will be increased. It will also decrease the pulmonary congestion, and there will be also a reduction of the manifestation, especially the difficulty of breathing. Those are the things that you're gonna expect. Again, there will be a decrease in the pulmonary congestion. There will also be an increase in the cardiac output. And finally, there is also symptom relief. Okay, so think about the IABP as one of those means to decrease the systemic vascular resistance, or known as the afterload. Okay, now let's move right along with the other complications here. So the complications namely will include the dysrhythmias. So if we are not able to control the pulmonary edema of our patient, we are gonna end up with a much more problematic scenario here. The patient will go into irregular heart rhythm that will become life-threatening. And we want to make sure that we are preventing these, because with that compromise in the cardiac function, this can overall worsen the patient's condition. And also another complication is respiratory failure, because the pulmonary edema itself can impair the gas exchange, and also the lungs will not be able to provide sufficient oxygen into the blood, and will also be causing a buildup of the CO2. And definitely we're going to end up with placing the patient into the mechanical ventilator in order for them to breathe effectively. Now, the right-sided heart failure is going to occur as a result of the pulmonary edema. We are going to make sure that the patient's manifestations are well controlled. We're going to have to decrease the circulating fluid volume because of that malfunction. Now let's move towards the nursing assessment findings here, or the nursing interventions that we can do. We're going to have to monitor the patient's breath sounds, take note of those adventitious sounds such as the crackles, the wheezes, or the rhonchi. These are indicating that there is now fluid accumulation inside the lungs. We don't want this. We really want to reduce the excess fluid in the lungs, so we can get rid of that with the use of the diuretic. We're also going to have to assess the patient's level of consciousness. So if you're going to notice any changes in the LOC, then that is actually signifying that the patient is not getting enough oxygen to the brain, and our goal here is to maintain oxygenation. Now, for the other assessment, we're going to have to assess if there is decreased cardiac output. So what are those signs? The patient will have increased heart rate. There will be diminishing pulses in the lower extremities or the distal pulses. The patient's skin will be clammy, it will be cold, and they will be having that pallor and also a reduced urinary output. So these are signs that you need to pay attention, guys. Now, for the assessment, we are going to need to continuously check the patient's cardiac function and look for those life-threatening arrhythmias. So make sure if you're seeing any of those deadly arrhythmias, notify the medical provider right away. or if there is any standing order, if we have medications to administer, if their patient goes into arrhythmia or premature ventricular contractions, or let's say VTAC, then definitely we need to carry out those orders. Now, if there is a hypoxemia, of course there is going to be, we're going to have to administer the oxygen through the different routes. Could be the nasal cannula, could be the mask, could be the venturi or the simple mask or the non-rebreather mask, or maybe with the use of the BiPAP as well. Now we're also going to have to monitor the patient's arterial blood gases and also the pulse oximetry, and we'll make sure that we are going to adjust the amount of oxygen that we are delivering according to the values. And part of the care here, very simple, we are going to elevate the head of the bed in order to allow maximum lung expansion, in order to facilitate much more effective exchange of the gases, and also maintain the bed rest during the acute phase, because this will lessen the workload of the heart. And we will be administering the medications like I've said in the treatment slide. Keep in mind about the diuretics. We're going to get rid of the excess fluid. The vasodilators will be used in order to decrease the preload, decrease the afterload. Same thing with the morphine. This is going to decrease the anxiety of our patient. When the anxiety is decreased, this will also decrease the oxygen demand. And with the use of those different inotropes, the cardiac glycoside digoxin, the dobutamine, the milrinone, and so much more. So think about the positive inotropic effect, which will enhance the ventricular contractility, which will be enhanced by these medications. Now, guys, we're going to talk about the patient education. What will be included here? Well, we are going to emphasize here that they need to be compliant in adhering to the medications, especially to make sure that they take the duration of the therapy, and also that they need to start modifying their lifestyle, which is really gonna result to some massive changes in their lung function. And also we're gonna emphasize that they need to show up for their follow-up appointments and make sure that they are gonna really make that call, that they need to be there in order for them to have that conversation with a medical provider if they're still not responding to therapy. Maybe there are some more modifications that can help this patient to really achieve a better or let's say an improvement in their cardiopulmonary function. Now, we're also going to talk about the different signs of the worsening condition, and this is very important, especially when we are going to discharge them to their home setting, and to let them know what signs that they need to recognize in order for them to seek help, that they can call their medical provider in order to address these emergent issues. And also there will be a need to change their diet, especially reducing the amount of sodium intake in order to prevent the accumulation of fluid or excess accumulation of fluid in their lungs. Now, guys, before I'm gonna end here, I really want you to point out which part of the discussion that you were not able to understand. And I think that somebody complained about the notes. Can you please point out which side of those, which part of the lecture wasn't really clear enough for you to see the notes? Can you please point out, please? So I can address that right away. Okay. So right now, I just want to hear your feedback. If you want me to go over with those sections that you were not able to understand. Okay. All right. So I'm still checking the comment right now. And so we're gonna have a short recap here regarding the two disorders that we just talked about. Okay. Now, I really want to emphasize regarding the care about the pulmonary edema and also the cor pulmonale. Again, the mechanisms are quite different. However, the manifestations are actually quite similar. And I really want to emphasize about the patient's education is very important between the two disorders here. We want to make sure that we are emphasizing the adherence to medication regimen, also the lifestyle modification, and also making sure that they are going to show up for their regular follow-up appointments, and also to make sure that they're able to recognize those manifestations that will signal them that there is an ongoing problem or any complications that might arise. So make sure that they're able to identify these so they can notify their medical provider. And I hope, guys, that you're able to gain some valuable insights from this lecture. I really want to know your feedback, and also we can give you some clarification if you have any questions about the complexities of the nursing care. I hope that I will see you again tomorrow, and we're going to be talking about the tuberculosis, and we'll focus on the nursing care. So till then, I'll see you tomorrow. You have a great day, and you take care. Bye-bye. Oh, okay. So I wasn't able to exit right here. So the EKG part. So this is Marie-Fleur Jean. Okay, thank you for that. So let me go back. I hope that you're still, guys. Are you still there? Okay. Let me go back to that section real quick. The EKG, and I think you're pertaining about, let me go to the next slide. Pulmonary edema. Okay, I think we are talking about the, let me go back into the cor pulmonale. I think that's where it was that you're pertaining. Let me just go back to that real quick, guys. Let me just catch up. Treatment. Okay. EKG. All right, so this is the section I believe that you were able to okay, let me erase all those. Okay, so back to the cor pulmonale. I think this is the section that probably you had a problem looking into the notes. So we're back in the cor pulmonale diagnostic evaluation and focusing on the EKG part. So this is where that you need to pay attention into the different waveforms, especially with the R waves. This is signifying that there is right atrium hypertrophy. Okay, so there is enlargement of that chamber. And the P waves, okay, this is gonna symbolize that there is right, also right ventricular, again, right ventricular hypertrophy for the right, for the tall R waves. However, if there is right atrial enlargement, then there will be peaked P waves. Now, there's also inversion of the T wave, which is really going to be evident in the precordial leads V1 up to V4. And with the QRS complexes, there will be low voltage there. And so you will see a shortened height of the QRS complexes. This is what we call as low amplitude. And the patient will also have that either incomplete or complete right bundle branch. Okay, so what you're going to see here is that there will be widening of the QRS complex, and also an RSR pattern in lead V1. So again, this is complete and incomplete right bundle branch. And so going into the echocardiogram, this is going to give us an idea that the patient is not able to properly pump the blood from the ventricle. There is weakening of the right side of the heart. And so the right side will also start to dilate, okay? And the ejection fraction will be decreased as well. The percentage will be decreased less than 55%, okay? And then there's also that right-sided cardiac catheterization, which will reveal the diagnosis, of course, that there is really a cor pulmonale. Also, it will be able to assist the medical provider in diagnosing the pulmonary hypertension. And the ABGs will also give us idea about the different imbalances in the partial pressures of the oxygen and the carbon dioxide, and also the pH. So this will help us in treating the patient's hypoxemia, so we can adjust the oxygen therapy, okay? Or let's say if they're using the BiPAP or maybe the Venturi mask, we'll be able to adjust the levels of oxygen accordingly. Now for the pulmonary function test, this will give us more information if the underlying cause is caused by the COPD, right? So if there is emphysema or the acute bronchitis, then definitely this can affect those vital capacity and also the tidal volume and everything as well. Now the VQ scan, what is this? This is a test that will be useful in determining if the patient has some pulmonary embolism. And of course, this is going to give us an idea if the patient probably has an allergy to the CT scan, if they cannot really if they're not going to qualify for that testing because of their allergy or adverse reaction from the dye, then the VQ scan will be used for them in order that the medical provider will see the perfusion function and also the ventilatory function of the lungs, okay? Now, the chest CT is also another tool that will be helpful in diagnosing the interstitial lung disease to check if there is pulmonary edema. And for the hematocrit levels, this is going to reveal if there is hemoconcentration, increased RBC, such as in the case of polycythemia vera, and it's going to make the blood so viscous, so thick, that it will cause strain to the right side of the heart, okay? So this is the significance why we are going to look into the hematocrit levels. Now, the alpha-1 antitrypsin, this is another testing which is going to give us an idea if the person has a problem in creating that lung recoil or promoting that lung recoil. So this is something that will be seen in a patient with emphysema, a form of COPD. Okay. So if they're going to figure out, hey, this is a patient that has a deficiency of the alpha-1 antitrypsin. So we are going to have to deal with the COPD of the patient, and hopefully this can improve the patient's lung function and also will lead into an improvement in the cardiac function. And lastly, we have the anti-nuclear antibody level, which is going to detect if a person will have a collagen vascular disease. And so guys, I hope that you were able to capture those items that you were not able to get earlier. And please throw in your comments so I can address those tomorrow. Again, I'll see you again in the next session. We'll be talking about the tuberculosis. So thank you and have a great day. Bye-bye.